Hydroxychloroquine has received lots of attention lately, mainly due to one trial coming out of Marseille, France. President Trump has been partly responsible for creating the hype. In this tweet, he said, "Hydroxychloroquine and azithromycin taken together have a real chance to be one of the biggest game changers in the history of medicine. The FDA has moved mountains. Hopefully, they will both be put in use immediately. People are dying. Move fast." So that's the paper by Professor Didier Raoult and co-workers from Marseille, France. Hydroxychloroquine and azithromycin as treatment of COVID-19, results of an open-label, non-randomized clinical trial. They recruited 26 patients into the intervention group. They were all recruited in their own center in Marseille, and 16 controlled patients who were recruited in Nice, Avignon, Briançon, or Marseille. They all tested positive for the virus at baseline. They then either received 200 milligrams of hydroxychloroquine 3 times daily, with or without azithromycin, or no treatment. The study's outcome was the clearance of the viral RNA from nasopharyngeal swabs that were tested with PCR on days 1 through 6. PCR basically looks for viral RNA in the specimen. Now, ideally, we would like to test a drug's efficacy using treatment randomization, where it's decided by chance who gets the drug and who doesn't. Also, in an ideal world, patients who don't get the drug should receive a placebo, and all participants, patients, and doctors should be unaware of who gets what. That's called blinding. Now, we are in an emergency pandemic situation and we need insights fast, so it's understandable that a formal randomized controlled double-blinded trial was not performed. What we would like to see in a trial like that, that's done quote-unquote quick and dirty, is balanced groups. We would like to see at least some type of matching of participants on important variables like age, gender, center, disease severity, and disease duration. Here are the patients taken from the paper's supplementary table 1. In order to give you a better overview, I marked the asymptomatic patients green, patients with upper respiratory tract infections yellow, and patients with lower respiratory tract infections red. So from less severe to more severe disease. And you can see that the hydroxychloroquine group seems to be much sicker. This to me suggests that the hydroxychloroquine group might actually have more advanced disease than the control group. As we move on, you'll see why that is important. Also, there were a couple of very sick patients who were removed from the intervention group. 3 patients had to be transferred to the intensive care unit. 1 died, 1 left the hospital, and 1 left the study due to nausea. Now, in a proper analysis, called intention to treat analysis, which they could have done, these patients would still have to be included in the overall endpoint efficacy calculation. In this paper, they were just simply removed. Now, as you can imagine, removing the very sick from the treatment group could make the final results look much better than they truly are. So here's how they assessed their chosen outcome: the presence of viral RNA in nasopharyngeal swabs on days 1 to 6 after the start of the study, seen over here in the 6 rightmost columns. They used cycle threshold to see if a test was positive or negative. The cycle threshold is the number of cycles to be run for the PCR test to turn positive. In this analysis, negative was defined as a CT value above 35. The lower the number, the more virus that is present, and if the number is higher, the less viral RNA is present. One thing I haven't mentioned yet is that these folks down here received azithromycin on top of their hydroxychloroquine. And according to the authors, fared even better. When looking at the proportion of negatives on days 3 to 6, we can see that up to 100% have cleared the virus. I'm not exactly sure what the rationale was behind giving both drugs in combination, assuming that they would have added benefits, but it seems to me like a very risky endeavor. These 2 compounds are known to prolong the QT interval, which in turn can cause severe rhythm problems known as ventricular tachycardia, seen here. So let's recap the major problems of the study we've encountered so far, which is groups not being comparable, incomplete testing in the control group, patient dropouts, inconsistent reporting, and a potentially dangerous combination of drugs. But we haven't even touched upon the biggest problem of all, and that is an incomplete understanding of the disease pathophysiology and course on the part of the investigators. Now, we know from virologic studies that virus load in the nasopharynx goes down in almost all patients in the first 10 days of symptom onset, even in those who later develop severe disease as seen in this patient. This is an example of a patient that developed pneumonia. As you can see, the viral load in the nasopharynx goes down, whereas the viral load in the sputum remains high because the sputum comes from the lungs and therefore better reflects the true disease process. What's happening in the nasopharynx has nothing to do with the severity of the disease. Testing for viral RNA in the sputum would have been much preferred. And obviously, what would be even better is to have hard clinical outcomes like recovery rate, duration from start to finish of symptoms, or regression of changes seen on the CT scan. These are the things we really want to impact with treatment, not the viral load in the nasopharynx.